Right. Hi, good afternoon, everyone. Welcome to everyone who's just joining us. My name is Chris Graham. I'm the Group Chief Executive at PENNA Institute. We're a charity based in Oxford in the UK with a vision of the highest quality person-centered care for all, always. We're proud to be partnering with the Patient Experience Network on today's webinar, which is about involving staff and patients in improvement work. At PICA, we view patient experience and staff experience being measures of the quality of person-centeredness in care. We spend a lot of time working to measure, understand, and improve people's experiences. But some of the best improvement work that we see from the organisations that we collaborate with is work that involves staff and patients as partners in co-production and co-design. So I think that co-production really is that we should all aspire to, not just a buzzword in health and social care. That's what we're going to be talking about today. I'm going to start off by doing a little bit of basic housekeeping. As you all know, the webinar is scheduled for 1 hour, so it'll be running from 2 to 3 p.m. We will be recording throughout that time, so by attending, I'm obliged to say that you are consenting to being recorded. If you'd like to keep your camera off, you're very, very welcome to do so. We will then be sharing that recording within 48 hours, and both via email to all of our attendees, and we'll be making it available on the PICA website, so that you'll be able to access all of that. We ask people to stay on mute throughout the presentations, and we do have the power to selectively mute you if we need to use it, but I trust everyone will comply anyway. We will then be taking questions towards the end of the meeting. So we will be hearing 3 sets of presenters first, and then moving to questions. If you want to raise any questions throughout, you should find on the top bar of your Teams window a Q&A button, and you can use that to add questions, which we'll be able to keep track of a lot more easily than if they appear in the chat as we go. I've just seen a message from Kelly Morley saying she can't hear anything. Is everyone else hearing me okay? Yeah, okay. Hopefully one of my colleagues may be able to provide a bit of tech support there, Kelly, and we can get you up and running. On those questions, sorry, I was going to say, if you have questions that go into the Q&A and we miss them at the end or we don't have time, we'll deal with those in writing and we'll provide a response subsequently. So all of the questions are going to get an answer in one format or another. As I said, themes today are going to be about co-production and collaboration. For that reason, I'm particularly pleased that we're collaborating so closely with the Patient Experience Network on this event. We're going to be hearing from 3 sets of Patient Experience Network national shortlisted projects today. But first, I'm just going to hand over to Ruth Evans from the Patient Experience Network to say a little bit more about the organisation's mission, about the importance of collaborative care, and about plans for PENNA 2023. Ruth, over to you.
Thank you, Chris. And I had put myself on mute for fear of being muted by the centre. So first of all, thank you, Chris and the team. Thank you to our speakers and thank you to our audience for inviting PEN to the party today. We're really delighted to be here and I think we're in for a treat. I was asked to say a few words and I was very lucky in that I was recently joined a training session that I wasn't running actually, I was being trained and it was just brilliant to be listening. And I was listening to a patient advocate, Jan Geisler, who has set up a couple of patient advocate organisations across Europe, Advocates for one and UPATI for another. And he was telling us about the history of patient involvement and patient activism and the patient voice. And he mentioned the Denver Principles. I am embarrassed to say I knew very little about the Denver Principles. And the Denver Principles were born in the 1970s. In the 1980s, sorry, with the HIV activism. And it was very simply, it was nothing about us without us. And they were driving this principle because they wanted people with lived experience of a disease or social reality to be the central voice in decision-making about directions in policy and programming that affect them. And I was intrigued because I was amazed that A, I'd never heard about it, and I'm just showing my terrible ignorance. But B, when I dived in and had a little look into this further, that wasn't the first time that nihil de nobis sine nobis came about. That's the Latin for nothing about us without us. Now, I am actually a Latin lover, and again, I'm a bit shocked that I didn't know that. But that came out in the 1500s. And that was used to communicate the idea that no policy should be decided by any representative without the full and direct participation of the members of the groups of people affected by that policy. And I was just really interested in the fact that this is not a new idea. And yet it's still quite new to us to ensure that patients and staff who are both affected by the decisions around the work that you're doing are often still not included in the decision making, which is in part why PEN was born, because PEN was born about just over 10 years ago. We're about to be a teenager. So we're going to be 13 very soon, and I'm sure we'll be having a few growing exercises and perhaps a few tantrums. But that's why we were set up, was so that people who are doing this great work to improve the experience, and typically having the patients and colleagues at the heart of their thinking, needed a platform to be able to celebrate and share and to be recognised for their great work. So that is, in essence, what PEN sets out to do. It sets out to create the opportunities for people to put forward best practice, for that best practice to be recognised, so that organisationally you can celebrate and have a bit of a party about the great work that you're doing. But really importantly, then share that so others can learn. And that's why this webinar is so crucial. If you're not aware of PEN, we are at the patientexperiencenetwork.org, and we run a national award programme to recognise the good work. And as Chris said, we're going to hear some of the examples. If you'd like to enter, we'll be opening very soon in March-ish. It may just slip into April. We're just setting up a new portal. But we are there to support you to spread your brilliant word. So whether it's co-production, co-design or co-creation, because I think we use the words interchangeably, although interestingly, they're not the same. We're here to recognise the work that you're doing, and just a wonderful chance today to hear 3 of the great examples of best practice. That's all I was going to say today. I have Louise by my side, so if you have questions specifically about entering or about the submissions or about the other examples of best practice, please do pop them into chat and one of us will be able to answer your questions. If not today, then we'll pick it up after the call.
Wonderful. Thank you very much, Ruth. Pleasure to have you here. And likewise, Louise, and we'll look forward to coming to you in the questions at the end. We're going to pass over now to the first of our presenters, and I'm very pleased to introduce Claire Delap from NHS Kenton Medway. Claire's going to be talking about co-producing a long COVID assessment and support service. Claire, over to you.
Thanks very much. Thank you so much for inviting me to come and speak at this event, and to PEN for the opportunity to get an award for our work. I was going to be joined by my wonderful colleague Rachel, but she has fallen ill last minute, so we wish her the best. I'm going to talk about our work to co-produce or co-engage long COVID assessment and support service for Kenton Medway. So next slide. Just a couple of quotes from the people we've been working with. Next slide. So I'll talk to you about who we are in NHS Kenton Medway, about the background, why it's been so important to work with people with long COVID, and tell a little bit about our story, how people got involved, how we listened, what happened, and views from patients and staff, why co-production made a difference. So I'm an engagement lead, and I worked on this project with the team who were planning and delivering sort of services around this new condition that was coming through for us. Next slide, please. So NHS Kent and Medway is an integrated care board now. We are responsible for planning and buying health services to meet the needs for the 1.8 million people living in this part of South East England. We have a really varied population, pockets of big inequalities, and a lot of rural areas, as well as a lot of big towns in our patches of Kent and Medway. There's the budget we had, it's going up because we're getting more services commissioned from out of our services, and we're very proud to be part of an integrated care system, working really closely with our 2 local authorities on improving outcomes across our populations, on trying to tackle health inequalities, enhancing productivity and looking at our budgets together, of course, and supporting broader and social, economic and development. Next slide, please. So back in 2020, long COVID was emerging. Very little was known about the condition. It became clear that for some it was really becoming life-changing. We were thinking that around 10 to 13% of people were developing long COVID, and that could mean around sort of 11,000, 14,000 patients for us across Kent and Medway. It's fair to say that the people experiencing this condition that was emerging and their families felt really ignored. They were calling for much more dedicated support. And in our area, they were calling really loudly, I have to say. We knew we wanted to develop an assessment service, but we wanted to work not to tell people what we were doing, but to work together with them. So it would focus most on sort of what mattered most to them. And when we started to listen, we sort of realised that some of our first ideas really needed to change. Next slide, please. So there were sort of 4 steps to what we've been doing. This describes, in a way, our journey. Right, sort of relatively early on, we wanted to try to understand people's experiences a bit better. So I suppose you might call this a bit of a research and outreach stage. We worked with our Health Watch and some of our community organisations. We ran focus groups, we ran surveys, and we held a series of events, workshops, and that informed our first post-COVID assessment service, opening them up. We then set up a patient reference group from some of the people who'd been involved so far, and people with lived experience, people with COVID, long COVID, became part of a sort of a Kent Medway wide cross-organisational delivery group, so trying to improve what we were doing. The reference group told us really clearly that more was needed, and so we thought, well, how will we do this? We ran a series of further events and exercises, surveyed our residents again, talked to our patients who were already involved, and very clearly came up with the need for a better, more enhanced service. And that the co-design of a new rehabilitation and support service is kind of where we've been in the last few months, nearly the last year, I suppose, patient reference group members and others helping us write the specification for that. Next slide, please. So it's really important when, as everybody on this call will know, it's really important that when we're working in partnership and when we work, for those of us who work in statutory bodies, to be able to demonstrate what we've done as a result. We can't do everything that people need and want as quickly as they want that, but we have to be really honest about this. And these are some examples of how all the way through what people told us informed what we did. So right from the start, families, residents were saying to us, people with long COVID were saying, our symptoms aren't being recognised and they need proper assessment. So we set up an assessment service. That was one of many in the country. It's nothing particularly special, but we set that up to start with because they were telling us that. They also told us, our GPs, our clinicians, our employers don't really understand this. They're not really, some of them aren't really believing us. So we got together with our patient reference group and they made a film, which we circulated widely, and we got them to help us with some education sessions. And we had a much higher uptake as a result from GPs across our system referring into the PCAS service. They also told us really early on, people with long COVID, that this new condition, this new experience that nobody really understands, peer-to-peer discussion support has been really, really helpful. So we've been setting up, working with our voluntary and community sector partners to set up peer support groups, and that's been going down really well. But the most important thing people have told us was, yeah, it's all very well providing an assessment service, but what about proper rehabilitation and support, including ongoing management of our care? And we asked them to help us write a specification for this new rehab and support service, because we know that what we've been doing hasn't been good enough, and we are going to improve it with their help. So that's been the really, really big thing that patients that we're working with will see changing gradually at the moment. Next slide, please. This is, hopefully, if it works, a small film of how people both working on this project from sort of all sides have experienced it. Thanks.
My name's Darren Winch. I've been suffering with long COVID for just over 18 months now. We're all learning as we go with this illness. There is no quick fix for it, but doctors, health professionals, everybody lets us sort of tell our story.
My name's Rachel Paris. I'm the Deputy Director of the Health Improvement and Transformation Team at NHS Kent and Medway. We have 5 patient representatives on that group. They are active members of the group and are very vocal in that forum around their experiences. And although that can be challenging to hear for partners around the table, it also really, really focuses us on the job at hand.
I'm Sophie, and I have had long COVID for 2 years and 3 months now. We've always been given that sort of platform to raise our hand in a meeting and for it not to feel too daunting, and that our suggestions and what we have to say, good and bad feedback is welcomed.
My name is Abigail Kitt. I work for NHS Kent and Medway, Deputy Director for the Health Improvement and Transformation Team. It has been an emotional experience working with patients, people with long COVID, but it's also been enormously rewarding part of my career, really, and it's really brought me back to the values of the NHS, which is creating services by listening to the people that use them.
It has changed our lives enormously, and I've just found the ability to talk to other people and to be listened to and taken seriously has benefited me a lot.
My name is Claire Delap. I'm an engagement lead for Kent and Medway. 3 things stand out about this as a piece of good engagement. Early engagement was really important, and so people's voices shaped things from the start. The second point is that the engagement carried on, that it wasn't just a one-off, through a group of patients from the reference group who come regularly to delivery group meetings and representatives, and through wider survey and focus group work, which we have carried on all the way through the service to develop it. And the third point, which makes this work stand out, is that people with experience themselves of the condition have really shaped and influenced what is planned in the service, what's happened in the service. So they've really been listened to.
Everyone that was involved in setting up the patient engagement meeting has sort of fostered a really positive culture in which patients really are heard and felt like they are actually contributing to the sort of the good standard of care or excellent standard of care that we want to give.
We've absolutely had to use our experts, which are the people with long COVID themselves, and it just reminded me how powerful and how important the lived experience of people with these conditions is in us really developing services that meet the needs of patients.
They help us drive the work forward, and it's actually a pleasure as well as a challenge to have them there.
Thanks. Next slide, please. I've got a couple more
And we're nearly done. We can go to the next one. There's a couple of quotes from out of that film. So last points from me. A few lessons from doing this. Because this was a new condition, as Darren said. It was a really good opportunity to learn together. There wasn't a sort of a so-called established clinical expertise. It was being built at the same time as we were learning from patients, and I think that was really important. But a few things that we didn't do quite as well, a few reflections or points to be made going forward for us. I think a challenge now is how you keep involving people over the longer time. What's the role of people and patients and families in monitoring and in ongoing improvements? I think we're quite good in the NHS at, well, we should be quite good that when we're doing something new, we go and talk to people. But do we keep involving them? That's a harder thing to do. So that's one of my reflections. Another is that we haven't involved all communities as much as we should have, and we're getting better at it in this particular project. So we're doing some work at the moment with some of our South Asian communities to look at their very specific experiences and what they need out of the services. So, we haven't done as much on that as we should have, but we're doing more. I think the main thing, though, is that we put this forward for a PENNA award because we wanted it. We thought there was nothing particularly special about it. It should just be what all commissioning or decision making in an integrated care system like us should be like. They should all be led by people with experience and with lived experience working in partnership, and getting it recognised has been good, but making it part of the day job is our biggest challenge, I think, now. So, and I think one of the reasons that's the challenge, and really this is my final point, is that working in partnership in this way with patients and families requires sort of three things. And this is tricky in the climate of the NHS at the moment, and everybody on this call will recognise this. It requires understanding, so a certain amount of expertise. It requires capacity in terms of time, in terms of sort of giving people the time to get involved and staff the time to listen. And it does require a certain amount of courage. My colleagues who were choosing and deciding on services could have chosen not to listen to people, but they did, and it's built a better service because of it. But there is a certain amount of courage attached to that. So making this part of the day job is my sort of is our next task, I suppose. It shouldn't be a special thing. So last slide. That's us. Thank you very much for listening, and thanks particularly to all those patients who've been involved in our service development with long COVID in Kent and Medway.
Thank you, Clyde. Great presentation, and really enjoyed the video as well. Great to see some of the people you've worked with talking in their own words. I'm going to just hold any questions until the end. We're going to move straight on to our next presenters now. And joining us from Cheshire and the Wirral Partnership NHS Foundation Trust, we have Jenny Scott and Fiona Jenkins. Jenny is the Specialist Mental Health Project Manager at the Trust, Fiona is the Specialist Mental Health Project Manager, and Jenny is the Associate Director of Commissioning. Jenny and Fiona, over to you.
Brilliant. Thanks very much, and good afternoon, everyone. Can I just say we're delighted to have been given this opportunity to tell you about the work we've been doing across our two provider collaboratives in the Northwest. And I just wanted to echo what Claire's just said, is we're going to tell you a bit about the work where we've been working with people with lived experience in our two provider collaboratives. And whilst, we've just started this work, this should be the way we do things. It's a cultural issue, and just sort of fully support what Claire said about, this should be business as usual. So I'm just going to say a few words of context, and then I'm handing over to Fiona, who's going to tell you about the work and the really important things that have come out of our working with people with lived experience. So next slide, please. So this is just a map. We're obviously in the Northwest, the purple bit. We have two provider collaboratives, one called Level Up, which is our young persons and families provider collaborative across Cheshire, Merseyside. You can see that there, and that serves a population of around 3 million, with both NHS and independent sector providers. We've got a number of challenges facing our young people's mental health services. Post-pandemic, we're seeing increasing referrals into services, and particularly young people with quite complex needs. And we want to look at where we can offer the best packages of care for young people. They often get either delayed admission into specialised services or delayed transfers out. And so we work a lot with our different partners around that. We have our empowered Northwest Adult Eating Disorders Provider Collaborative. Much bigger footprint, covers about 6 to 7 million population. Again, both NHS and independent sector provision. And some of the challenges facing them is, again, increasing numbers of referrals and making sure we see those seamless transfer between community-based services into the more specialised services and then back out again. So that's really a bit of context for those two provider collaboratives. I'll move on to the next slide, please. So very small text, you'll see this when the slides come out, but our ambition for change is NHS England set up provider collaboratives to be innovative, to be creative, and to really drive change in specialised mental health services, care closer to home, outside of hospital, and fundamentally working alongside people with lived experience to say, what's the reality to them? What do they want to see? What was their experience? And how do we move forward together? So we want this to be a cultural thing, as Claire mentioned. And this isn't a soft option. You know, people saying, well, you know, you need to get down to hard facts and hard strategy. This is really fundamentally important for success, is that you work alongside as partners in everything that we do in all our groups. And that's what Fiona is going to touch on in a minute. Next slide, please. So that person-centred approach isn't a soft option, but is fundamentally important. And we work across complex landscapes with many different providers and commissioners and new organisations. And so in everything we do, we always try to place the person at the centre and their families to learn from them and their experience. Next slide, please. So we're a commissioning team. We're a commissioning team inside a provider, inside of a mental health trust provider. And this is part of the delegation of commissioning responsibility from NHS England. So we've got the role to look at this strategy, the contracting, the commissioning of these two services to make sure that we're moving forward to meeting all national guidelines and that these are developing. And so we recognise that people with lived experience bring that unique perspective into our commissioning plans and into our partnership working. A great believer in being honest and open. I have worked as a commissioner for many years, and my colleagues were always a bit anxious about engaging with people with lived experience, their families, because what if I can't answer their questions? What if I can't meet the challenges that they're posing to me? And our view in our two provider collaboratives is that we'll just be honest and open. There will be challenges and barriers, but we'll work through those together as partners. We try and base all our decisions on evidence-based. Oh, sorry. And then just one other thing before we move on is our names. That's Empowered, and it's Empower ED, standing for eating disorders, and Level Up were chosen by our focus groups of people with lived experience because they felt those two names and the logos and everything really articulated the ambition of these provider collaboratives. Next slide, please. So again, teeny-weeny writing, so you can read these at your leisure, but it just really says what I've said about being transparent and honest. And this is not optional. We don't just seek to engage with people with lived experience now and then, or when we've got a bit of a big piece of work. It's really hardwired into our governance through specific groups and through membership on all of our key groups. And it is a cultural focus, as we've spoken about, and not only people with lived experience, but also broader community engagement. So I'm going to hand over to my colleague Fiona now, who's going to show you some examples of what we've been doing.
Next slide, please. Thank you. So part of the process back in June, we commissioned BEAT, Young Mind and IMO, who are known as Inspire, Motivate, Overcome diversity leads. And together We worked across Cheshire and Merseyside and also across the North West to recruit experts by experience to join the forums. There's 2 forums, 1 for each LPC. And we have, it's a bit of a whistle-stop tour, but you can see the kind of group that we have at the moment. It was more tricky to recruit younger people because they were aged 13 to 18 with tier 4 experience. And obviously at that age, I may still be having support. But we have also recruited some young people that have experience at tier 4 and are in their early 20s. Next slide, please. We have a really strong cohort of experts by experience. So within the group, we decided, they decided who would sit on the clinical delivery group and partnership boards as representatives of the forum. Also, our kind of model is that we have a clinical lead for each LPC. We would discuss forum topics with the group and with the CDG and clinical lead. And it's a two-way conversation. So we're sharing information, we're asking questions, we're feeding back into the forum, they're asking questions. So we're equal partners, they are equal partners on the clinical delivery group and partnership board where change actually happens. So that model's working really well. And it actually came quite naturally. We have some very gifted people on each of the forums that all come with their own skill set. They're not just patients and carers, you know, they are people that have a background, skills, families, and knowledge that we can learn from. Next slide, please. The type of topics, I'll whiz through this because I know that you will see the slides later. Some of the examples of some of the topics that we were collected from the forum Empower ED and then brought to the clinical delivery group and partnership board. Next slide, please. A way the Empower ED like to feed back is we used this jam board, and this was with support from Beat. So we'll have a subject and then we're whiz through and then feedback and then we discuss. And then for participants that can't make the forum, they have the opportunity to feedback online at a convenient time. Next slide. We're going to whiz through these next slides. Next slide. The level up, some of the topics that the young people felt were really important to bring to the table to discuss. You know, they want to see the change. I think that was mentioned earlier. It's not just about talking, it's about the doing. So they will see that because they are part of the clinical delivery group, part of the partnership board, and they will have answers. And again, as Jenny said, we're very honest. If we can't make that change, if it's totally impossible, we give the reasons why, you know, and they're very accepting of that. And they may come up with a solution we haven't even thought of. Next slide, please. Part of this is going into the community. It's not just sending emails to our networks, it's getting out there and meeting people. So service users, patients, carers, you know, may have been through the service up to 5 years ago, but their input is still really important. So Duncan, Campbell and myself have been out with Empower ED and also raising the profile of Level Up to engage with the community. We've been to mosques across Wirral, Liverpool, Bain communities in Warrington, Lancashire, asylum seekers and refugees. We've engaged with people and we've asked them, what are the barriers to accessing support services? Is it within the community? Is it after that? And we've had some really clear messages back, which again, we take back to clinical delivery group, to the forums and have those discussions. Here, there's some pictures of where we attended the Mailer in Warrington, which is an ethnic minority festival, been to Liverpool Pride, you know, wherever we can go, wherever we can be, where the people are, that's where we go. So it's not just about speaking to people while they're under the services, it's about people that have already experienced historically and linking into our third sector partners. And it's been with the support of Beat and Young Minds and IMO, who have been fantastic to work with. It's about the extended third sector, faith sector, public sector. You know, what's being done, what are the barriers, what can we do better together? Next slide, please. Thank you. Before I play this, we've just launched the Community Champions programme for Level Up, which is fantastic to recruit ambassadors and community champions across Cheshire and Merseyside for Level Up, raising the profile of young people's mental health and carers support, and feeding information. We have a website where we feed information into, we have training for GPs, this is the plan, training for GPs, and also we have eating disorder training for schools. So it's a whole vehicle of education, information both ways, and to share communication. Okay, before we turn this video on, I know I'm running out of time because this is 3 minutes, this film, but I wanted to read out a quote from one of our experts called Ruth, who said, "I'm not my appearance, I'm not my diagnosis, I'm Empower ED." So it's about how the impact of having a voice, being listened to, being part of change, positive change, affects each person on their individual journey and supporting them through that. And it's mentioned earlier, it's not just asking people to open up. They are experts, we take that for granted, and they are far more than that. So we need to think ahead. We need to see how we can engage them in everything we do. They are core to everything we do. So I'm just going to ask you to play the video. This is one of our experts, Nicola and Duncan Campbell, the clinical lead from Empower ED. Thank you.
Empowered serves about 6 million people across the northwest of England. We have hundreds of dedicated professionals within Empowered, but we need to do better. Empowered will link NHS professionals, independent professionals, charities and experts by experience with the sole purpose of improving care for people with eating disorders. We need people to recover quicker without going into hospital. We need better services for people who have eating disorders and other health problems. And we need our services to be accessible for everyone in our community. We're using data, research and our clinical knowledge to work towards these. But we need to have the voice of our experts by experience to really focus our work. Our experts by experience will challenge us, guide us, and help us to make the progress we need.
Hi, my name is Nicola. I'm an expert by experience on the Empowered Forum. I was diagnosed with anorexia nervosa in 2017, and I was an inpatient from August to November 2017. I was then part of the CWP outpatient services until about November 2020. For me, it all happened very, very quickly, and I went from struggling without realising to then being admitted into a hospital. And if it wasn't for the support of my family and intervention by CWP, I don't think I'd be here today. One of the reasons I want to get involved with Empowered ED is that I was very fortunate to have these services, and I know that there are lots of areas in this country that do not have the kind of care and support that I did, and in particular even across the northwest, and that's something that we need to change. I also feel that I myself was pushed away and had to go on waiting lists, and I dealt with different services across the country from London where the GPs weren't aware or fully educated about the signs of an eating disorder in general, and the waiting times can be improved. And I do feel like talking to other people and getting the voices from other experts by experience, we can do something to change that, and how to reach out to people that might be struggling, and the ways in which we ourselves found support. I also feel that it's a very powerful forum to give a voice back to people that had it taken away from them. Anorexia, and for me, it was all engulfing, all consuming, and your voice is taken away from you, and you're reliant on your support network and consultants to help you through. And now I have that voice back. I have my voice back, where I can make changes that I think could help me or can help hundreds or thousands of others across our region.
Thank you. Thanks very much.
Thank you very much, Jenny and Fiona. Really interesting presentation. I'm mindful of time. I'm going to move straight on to our next set of speakers. Joining us from Liverpool University Hospitals NHS Foundation Trust and St Helens and Knowsley Teaching Hospitals, respectively. We have Alison, Germain-Martin and Yvonne Mahambrey. Alison and Yvonne, over to you.
Oh, thank you very much. So yes, my name is Alison Germain-Martin. I work as a patient experience and engagement manager at Liverpool University Hospitals.
My name is Yvonne Mahambrey and I am quality matron here at SDHK.
Just like to say as well, we're just representing our team. So I'm also joined by Alison Galley-Daly, who's another patient experience manager and also Cheryl Farmer and Francine Daly, who work with Yvonne in the patient experience and inclusion team. So hopefully they'll be available for the questions later if we have time. So as you can see, we too were shortlisted for a PENNA award, which was really exciting and a great opportunity for us to talk about this project. And like Claire, Jenny and Fiona have shared, I think fair to say that co-production is very key to our practice at both trusts. And I think what made us want to present this particular project was the fact that it was a regional collaboration, it was a regional co-production, and we'll talk more later about why we felt this was so important. Next slide, please.
So there were two fundamental aims of the project, accompanied by much smaller sub-aims. But the two main aims were that we wanted to demonstrate our commitment to working together with carers, because they really are expert partners in care, and to include them in the creation of the information and support document that is the Carers Passport, to ensure that it was consistent across hospital trusts throughout the whole region, because carers were telling us, depending on where they went throughout the region, that their experience of being a carer was really very different. So that was the first aim. And then we wanted to implement the Carer Passport in full as clear recognition of the vital role and contribution that carers make to their families, and fundamentally to enable that role to continue if they wanted, because sometimes family and carers may take the opportunity for a bit of respite when their loved ones are admitted to hospital. So it was a really, it was a non-obligatory role to continue that, and it was surrounded by a partnership agreement, which is within the document. Next slide, please.
So we felt this image was quite appropriate on many levels. It did indeed snowball, but at times it did feel a bit of an uphill struggle. I really liked the quote earlier about co-production needing understanding, capacity, and a fair bit of courage. Can really relate to that as well. But ostensibly at Luft, it followed following a merger of organisations back in November 2019. There was a huge harmonisation process, and I'm sure any of you that have gone through a merger will relate to that. And as part of that process, we were asked to look at the Carer Passport, and indeed at the different sites of the trust, a Carer Passport had been developed and used. And I guess what we wanted to do was introduce that ethos that Ruth talked so eloquently about, that ethos of nothing about me without me, and really ensuring that we worked with staff, we worked with patients, we worked with carers to really understand what that document needed to look like. But it was much more than a document. We wanted it to be a cultural change. And that's when we started to talk with Yvonne and Cheryl and Francine at St Helens and Knowsley. And as it happened, they were also reviewing their passport at this time. So we decided to work collaboratively geographically. We are quite near, and so we felt that that was a good way ahead. And that started that engagement process. And working together, we worked across the Northwest area. We engaged with both carers, carer associations, and at that time, still very much kind of limping through COVID. We did lots of virtual engagement events, which was huge learning for all of us. But we're really keen, as perhaps the other presenters have mentioned, about making that as inclusive as possible. And so we did sort of quite widespread engagement. We then presented the work at our regional Heads of Patient Experience Network meeting. And that started those discussions about, well, wouldn't it be great if we could extend that collaboration, if we could extend that co-production, and actually look to produce a regional resource. So that then the snowball got bigger and bigger, and we felt that there were huge benefits for us all, but most importantly for our patients, who often actually don't just come to us individually, but actually visit different trusts across the region. And so that then began that process on a regional basis and much wider collaboration. Next slide, please.
So it was key and was agreed that both the patient and carer perspective, it was essential to co-produce the passport. And as I alluded to earlier, it was fundamental in getting all the trusts on board to really make the carer's passport standardised for our region. And we had really good engagement from the other trusts through the Hope Network. And really that was to ensure that patients and carers would visit different trusts and would have the same experience really, and would be afforded the same things without, throughout that experience, and a consistent level of support. Next slide, please.
So these are just a few of the quotes from different carers that we worked with. And I think that they were repeated themes that need to be involved, and discharge was a very important theme for carers, and the importance for a successful discharge and mitigating against repeated readmissions and successful discharges. That was seen as very key. And just that very basic message that as carers, they are the people who perhaps best understand the needs of the patients. They can be a voice, quite literally, for the patients, and really allowing that carer into that dialogue, and that being a very key part of our care. That final quote was very poignant from one mother we spoke to, who said, "If I wasn't there, if I wasn't included, I really think that he would die." And that very powerful message at a time as well, after COVID and during different iterations of our restricted visiting, when many carers felt very excluded, and that I think sort of was resounding for all of us involved in the project. Next slide, please.
So this slide really covers those that are involved, what really motivated them to get involved. So these were both carers, and the first one, Doreen, said that she got involved with the carer's passport. She wanted the carers to have a voice and to ensure that they were listened to, and that it's also important to get some uniformity across different hospitals to be involved with the decisions about the person that we care for. And then that was followed by Muriel, who said as a long-term carer of her husband, she needed to be involved in his care in hospital. She really did feel strongly about that, particularly information sharing, and that she was interested in the idea of a carer's passport right from the very beginning. Information sharing is pivotal to the advantages of the passport. Next slide, please.
So we agreed across the region to have a consistent launch event, and we aligned that to Carers' Rights Day in November 2021. And you can see there, this was the document that was finally agreed, and this is the same document, as Yvonne said, used across the region. And you can see it's quite a different document. I remember when I actually took this to our clinical documents group, they said they hadn't seen anything like this before, and it's quite different from many of our corporate documents that we produce. And that was very, very much intentional to make it stand out, to make it look a little bit different. And one of the things that came through very clearly was that the carers didn't want us to use stock images. They wanted their photographs in the document. They wanted to have that ownership, that identity, and that their photographs are therefore used throughout the document. Next slide, please.
So there are passport benefits for patients and carers. So we'll just run through these. So a number of benefits include ensuring a patient's individual needs and preferences are understood, and sometimes patients may not be able to make themselves fully understood, and it is those carers that know them well and know them the best that are able to help verbalise those preferences. It ensures that carers can be present with their loved one to provide emotional support and reassurance when they may be frightened and anxious. So we have patients who are living with dementia and other conditions, meaning that the unfamiliarity of an environment can add to distress. and a familiar voice or a familiar, recognising a familiar person can really help with that and support communication and help patients to understand and really make sense of what's happening in the world around them, if that's very different to the world that they know. It encourages compliance with treatment regimes, so sometimes patients may be reluctant to take medications, for instance, from a member of nursing staff, but if a carer is there to encourage, then that often helps. And the carers can also encourage and support with eating and drinking, so they're really valuable with making sure that patients receive the right nutritional input and hydration. And then including carers in discussions, particularly around discharge, because we know that those discussions are best placed right at the beginning of a patient's stay. So they're really helpful in that. And then and then it helps to make an offer from the hospital really explicit. Next slide, please.
So I won't go through all of these because obviously there's a commonality with what Yvonne has just said. But I think what's really important when we talk about co-production, working with staff were able to identify what they needed from the passport. And it really, I think, highlights as well that the sort of equal partners in care with carers and staff. But this has also been really helpful to revisit this with staff when we've been implementing it onto wards, because we know that sometimes changing that culture can often be when staff are very busy, and we know that throughout our trusts at the moment we've got unprecedented attendance in our ED departments. We're having increased activity. We've got reduced resource. And actually, when we're introducing something new, it can often feel that, oh, this is going to cause me more problems, this is going to slow me down. And it's actually revisiting this with staff and reminding them that actually, that not only should we be introducing and including carers into that care for our patients, because it's the right thing to do, because it enhances patient care, but also it's a benefit to staff. It actually means that they will have somebody there to assist with nutrition and hydration and compliance with treatment and all the things that Yvonne has highlighted that were important to carers. And I think that's been a really a useful tool for us in the implementation and ongoing co-production and work that we've done in implementing this across our trusts and indeed wider across our community. Next slide, please.
So I'm just going to have to ask you to start wrapping up now, please. We're a bit over time.
Okay. So I think that the Carers Passport partnership agreement's in the document and in the slides. And I'm wondering, is the time for us to share the film that we've shared with the carer, so that if we just go straight to the film, please.
So Wendy, when we spoke last time, you talked about when Jake's been in hospital. What sorts of things are difficult for you?
When Jake is poorly, he clings on and wants mum. He doesn't want anybody else. So it's really hard. There may be a nurse to stand in, but at the time, Jake doesn't want that. So sometimes you're being rushed into the hospital. You don't even have a cup of tea because sometimes it's just not allowed. So I've been there particularly 3 or 4 days with no food or drink because I've not took money with me and Jake's not wanted me to leave his side. I think with a passport in place now, it states on it you can have a hot drink. It may sound trivial, but it's a massive thing. Car park concessions, you're stuck on this wall thinking this bill is going up and up and up because my car's in this car park. I think any help towards paying towards car parking, discounts you can get in the canteen if you can get down to the canteen because it's extra cost to carers. So I think it will make a massive, massive difference to carers.
And when Jake has been in hospital, when he's been discharged home, have you been part of those discussions?
I have, yeah, because whenever Jake is in hospital, I am with him at his side 24/7. So I am involved.
And is that important that you're part of those discussions?
I think it's really, really important because we all have to be singing from the same song sheet.
So Jake,
Yeah.
I know when you were in hospital, it was a little while ago now, and it was during COVID, and you were really, really poorly, weren't you?
Yeah, I was very, very poorly, and I was worried, sick, and I was rushed in hospital. I was worried because I got really, really upset.
So it's really scary for you in hospital?
Yeah.
Your mum knows you better than
My
me.
mum's the best.
So tell me when you're in hospital and mum's there. So she makes you laugh,
Yeah.
she helps you with the hard bits like needles, because you don't like needles at all, do you?
Yeah, but now I've been things actually let them put the needle in me now. Yeah, I let them do it now.
I know that you've said that when you get upset, sometimes you scratch your skin and make it sore.
Yes.
So when you've been in hospital, have you been? Did you scratch then?
You was very, very anxious.
Yeah, I actually raised my own skin and make it bleed. And my mum tried to get me 2 hands and say, "Come on, Jake, you can get through this."
You don't think that it should be called Down syndrome, do you?
That's right. It's called up syndrome.
Up syndrome. And why should it be up syndrome?
Because whenever there be Down syndrome, they are sad, but I am smiley. To best up syndrome I had.
Thank you, Jay.
I'm so sorry that we weren't able to share, because we can talk more about the work that we've done externally across the community with GP practices, nursing homes and other agencies, but much more important we felt to hear from Wendy and Jake, who obviously represent the people that are most important within this. So thank you very much.
Yvonne, Alison, thank you very much. And I'm sorry to have to hurry you. We are just very mindful of time, and I know some people will need to leave at 3. We're coming up towards the end of the allotted time that we have now. We do have a few questions that have been submitted in advance. I'll ask our presenters to give relatively brief answers so we can try to get through a few of them, and we'll then collate questions and answers and publish those separately. But Ruth, if I might come to you first, a very broad question to really put you on the spot. What's the key learning, if any, from the Patient Experience Network that you can share across the audience? Is there one take-home message about what works for co-production?
Oh, wow. Gosh. Well, I think you've just seen it. It's understanding that it's essential. You've got to start somewhere. I love the fact that it's embedded, but simply starting somewhere is the first step. So, and don't fall down at that first hurdle. I love the comment about going to the people. Find a way to go to the people. If they're not coming to you, go to the people. I'll keep it that brief.
Oh, it's a fantastic, succinct answer to a question that invited a very, very long answer. Thank you very much. Claire, we had a question for you, which is about how challenging it was to encourage people to participate in the project. And I think that's probably particularly with the long COVID project where people might be experiencing chronic fatigue. Was it difficult to motivate people to take part and secure their involvement?
It's certainly, people face a lot of challenges when they've got a condition like long COVID and other kinds of sort of chronic conditions, and there'll be some similarities with working with people with, for instance, eating disorders as well, as we've heard. I think you have to work on people's own terms about how much and how little they want to get involved. And so doing things online is actually a real advantage. It was a real advantage to us. So that helped, because people were able just to log into something while they were sort of almost lying down if they wanted to, and just have their say and switch the cameras off and then participate as they could. So that has actually really helped, that we've had been forced into so much online engagement. That's certainly helped a lot. So I think it's working with people in their terms and the way that they can manage and want to be involved. So we just try to do that as much as possible. But it is, of course, it's a challenge for people, and it's amazing the way they step forward when people are feeling rubbish quite often.
Yeah, no, that's great to hear. And it for me, it kind of brings to mind we always used to talk in engagement about going to people rather than expecting them to come to you. And of course, with digital technology now, it's so much easier to go to people without having to be out in the community in such an active way. If I can just move on, and Fiona and Jenny, a question for you. Have you seen a positive impact or an increase of services because of your project?
So I didn't quite catch that. An increase in.
An increase of services. I think this is about positive impact in general. So more access to services and better outcomes.
Well, I'll just say a word, and then Fiona will add to that. What we've got is listening to people who've actually used our services, and we're looking at service developments, and they're involved in those discussions, very much influencing what we're going to do. So we're still early stages yet, but I think we've got a bedrock and a foundation of engagement, of listening, and that is going to stand us in good stead for the future. So Fiona has done extensive work going to the people in the communities and understanding why people aren't referred, because we're working with the people who've experienced the services, but many have not been referred, and we want to know why they didn't go. But Fiona, you could add a little bit more to that.
Yeah, I think obviously we've been kind of targeting BAME communities because nationally there's less referrals, particularly around eating disorders and mental health services, specialist services. So it's about building relationships as well, really. So you can't just rock up and say, answer this. You know, you go there with into the community with something. So some of it is around training, accessing support, having those one-to-one conversations, and then the engagement starts. So then you're building the relationships and then getting to the core questions, really. You have to be very sensitive. I think the community champions are going to help. I don't know if I'm answering the right question, but the community champions will help because we'll be sharing the information within the community. It'd be an ambassador based in local authorities, schools. There's a kind of not a control, but we know who our community champions are. So we'll have an ambassador that links to community champions so we can feed back in the information about barriers to accessing support, and also sharing good stories and good news and up-to-date self-help. You know, it's right across the board, really, to work with our partners to do that. So I don't know if I've answered your question, but that's kind of the way we're targeting everything. It's like a big jigsaw puzzle. That's kind of the way I look at it. So yeah, thank you.
That's fabulous. Thank you very much. Just time for a couple more questions, I think. One for Yvonne and Alison. Is your approach with regional carer passports something that could be rolled out more broadly, and if so, how could it be potentially shared across other trusts?
So we did present this carers passport to the Hope network, looking at the rollout of the passport as a national document. And certainly when we came down for the PENNA Awards, we were approached by various trusts that wanted really to adopt something similar, and we were contacted and have had separate meetings following that. I think the principles are always the same, and as Ruth had said, or I think it was Ruth that said, if you can't get the people to come to you, you need to go to them. And it's been really important, certainly, because this isn't the end product. It's moving on from there, and how we develop it and how we roll it out and continue to continue with that momentum. So it really isn't an end product, but no matter what your journey is, or what your initiative, or what you want to do, the principles are the same, and you have to have patient at the heart of it. And we just are enablers to voice, aren't we? Really.
I think that was perfect, and I think, as Yvonne said, I think the principles can be emulated, and I think we need to start thinking about. I think thinking about it from that patient perspective, that so many of our patients, particularly with increasing amounts of complex medical needs, don't just come to one hospital or one trust. They come to numerous hospitals, numerous trusts, and we don't want them to have to feel they've got to start all over again every time. That the more that we can can work collaboratively, the more that we can then truly provide person-centred care. And I think it's looking at things a little bit more broadly, and just making sure that that ethos is central to everything that we do. Don't you want to? No, Thank you.
Okay, I'm mindful of time, so we're a bit over. I'll just ask one last question and we'll move to wrap up. And it's a question about sustainability. Claire talked earlier about the importance of making co-production part of the day job in order to sustain it over time. I wondered if any of our other speakers would like to share any thoughts, Claire, you included, of course, about how we can ensure that the work we do to engage and involve patients and staff continues to have a life and continues to make a difference.
I can say in terms of the work that we've been doing, our groups, we were originally a program. We're not a program. This is business as usual, and we have experts by experience on core groups, decision-making groups, clinical development groups. There is a forum. Fiona's leading a number of pieces of work. They've designed the website. They've got a little group that will update the website as they go along. And I think we've all spoken. All the presenters have spoken about this is cultural. This is not optional. And it is hardwired into our groups and into our governance, and this is sustainable. Our people with lived experience are as important as our clinicians, are as important as the managers on our groups. So our view is this isn't optional, this is the way we do business.
Such a powerful message. We sometimes hear people talking about co-production by default, but actually I love your articulation of it. This is about the culture. It's not optional. That people who are experts by lived experience are as important as the experts by training. I think that's such a wonderful message. I don't know if any of our other speakers wanted to jump in on that. If not, we'll start to wrap up and release people.
I think Jenny articulated it, really powerfully, and I think there is a danger, isn't there, when we know everybody is so busy. We know that services are so pushed that engagement broadly can be viewed as a sort of nice to do thing. But as Jenny has so powerfully illustrated, it isn't an add-on. It needs to be core to everything we do. And in all the different areas, whether it's service innovation, whether it's quality improvements, whether it's research and development, clinical audit, that patients, families and carers need to have a central role and be there as equal partners to the experts, if you like. So I think I think for all of us, and particularly for those of us working in patient experience teams, and it's making sure that in times where there is limited resource and everybody is so busy, that isn't seen as an add-on, and actually, that's something we'll come back to when things are less busy, because things are not going to get less busy. And this is now business as usual, and that co-production must be part of that business as usual, as Jenny has said, and everybody has spoken about today.
Can I just add one final thing on that? I think one of the things that this has demonstrated is that some parts of our system, across health and care, do this better than others. There's traditions and cultures in some parts of the whole of the health and care experience, sort of that have traditionally and continue to do, slightly better, more intrinsic user carer engagement, and so cross-learning and pushing from one part of the system to another, that this works, it is easy, I think is really a key to doing that. Getting as much learning, whether it's in a sort of a region like one of ours or across the whole country. So things like PENNA and things like this webinar, I think are really, really important.
Yeah, that's great. Thank you, Claire. A comment as well from Ruth in the chat, stop calling it an improvement programme. It's actually just how we do things around here, which I really like. I want to say a huge thank you to all of our speakers for presenting today. The work you've shared has been tremendous, really, really powerful message. And I'm sure will be hugely inspiring to people who are here to listen as well. If you are here as a guest listening, I hope you found the session useful. I'm really grateful that you've chosen to spend some time with us this Thursday afternoon. And I hope you have felt inspired by the stories that you heard and the work that you've seen presented. Of course, if you do feel inspired and you plan to do co-production yourself or to continue to do it, please do think about submitting making a submission for this year's PENNA Awards. We'll be delighted to see them. And if there's anything that we at PICA can support you with, please do get in touch. We'd be delighted to have a conversation about it. For now, I've gone completely over and I've just got time to Fiona. Did you want to come in? No?
I meant to give you a clap, actually. And the hand came up.
No problem. I just have time to say thank you all very much. I hope you enjoy the rest of your afternoon. A reminder that the presentation will be available online. So if you joined late and you missed part of it, you can catch up. We'll also be collating answers to all of the questions and we'll be sharing those in due course. So thank you all very much. And we will be in touch. Take care. Goodbye.
Thank you. Bye-bye.
Thank you. Thanks.
Thank you, everyone. Great session. Thank you.